Okay. Hi, everyone. Can you guys hear me okay? Okay, perfect. I wish you all a happy new year. Thank you, everyone, for joining the FCC Task Force 2024 first webinar. We are excited to embark on another era of family-centered care work with you. And we have two great talks planned for you today. So which are listed here. And first, I will be sharing a brief FCC Task Force update. And if you don't know me, I am Mallik Balasundaram, a neonatologist and one of the FCC Task Force co-chairs. We dedicate our webinars to one of our Executive Council family partners, NICU child or children. And so this webinar is dedicated to newly elected committee co-chairs, Morgan Kowalski and Nicole Nyberg's sons, Thomas and William. Next slide. So we are thankful for several esteemed organizational partnerships that help promote FCC practices in the NICU. We are honored to occur a recent partnership with the NICCAP Federation International. NICCAP stands for Newborn Individualized Developmental Care and Assessment Program. I want to welcome the liaisons, Deborah Bowler and Sandra Costa, to the task force. Next slide. We cannot sustain this without financial support of our industry sponsors, and Draeger sponsors this webinar, and their motto is care for babies like never before. And thank you for your sponsorship. Next slide. We have several new members in our task force, and which has grown to 760 plus members, representing 43 US states and 30 plus countries. We want to share this slide by acknowledging the FCC task force adopted the Next Society all-in meeting guideline to break down the hierarchy. We introduce speakers using their first names and want to create an inclusive discussion during the meeting. Please chat in your questions or unmute, ask questions during question and answer session. Next slide. This slide lists our task force core team. Kira, Colby, and I are co-chairs. Morgan is a program manager and keeps us organized. The core team has 2 healthcare partners and 2 family partners. Next slide. This slide shows our 18 diverse birthing and non-birthing family partners representing organizational leaders and local NICU leaders. We are honored to have their collaboration. Next slide. This is our Executive Council healthcare partners, and they have various roles like faculty mentors, small group leaders, and QA mentors. Thank you for your commitment to FCC. Next slide. So we want to have an equal partnership between healthcare partners and family partners at the leadership level. So we reached out to our Executive Council family partners and selected committees co-chairs. Alex Zavala is a co-chair for the marketing and communication team, and Morgan Kowalski is a co-chair of the newsletter committee, and Nicole Nyberg is a co-chair of the advocacy committee. We welcome all 3 of you and look forward to your leadership. Next slide. Okay, the new year has started. So you may ask, what's our plan for 2024? So we listed a few of them in this slide, and we completed a phase 3 small group QA work and working on collecting the end of year survey about their implementation of a family-centered care committee and family partnership council in their unit. We plan to share our results at the Gravens conference in March. We started phase 4 on benchmarking FCC measures among centers in 7 categories. We received family partners' feedback, and we are collating the responses, and we'll share it with the healthcare partners and finalize the survey to measure gap analysis. Next year in phase 5, we plan to work on topic-specific small groups to improve family-centered care. And this year, we plan to hold monthly small group office hours to discuss overcoming challenges around implementing family-centered care. Next slide. So we wanted to learn from each other in this task force. So we created a 1-question poll monthly, and please share your thoughts on way to recruit family partners to form the Family Advisory Council or Family Partnership Council. We have received great responses so far, and we will open the November poll until the end of January. Morgan will share the responses we received and the link to participate if you haven't. Next slide. January poll is related to recruiting centers for small group activities. Some centers specifically requested to be part of the small groups and task force. So this is your opportunity to join the small group office hours. We haven't decided on the dates or time. Stay tuned for more information. Morgan will share the link in the chat. Next slide. Remember to take advantage of the early bird discount for Grievance Conference registration. It's January 22nd. So the Grievance Conference is hybrid format this year. So you can join virtually if you can be there in person. FCC task force is doing 1 workshop, a podium, and 2 small group centers actually doing a podium presentations as well. We are so excited. And Morgan will share the registration link in the chat. Now I will hand it over to Morgan to introduce the first talk speakers, Priya and Sangeeta.
Hi, this is Morgan Kowalski, Program Manager for the Family Centered Care Task Force. Thank you all for joining us today. Our first presentation will be Evolution of a Family-Centered Care Program in a California Safety Net NICU. And we have Priya Jegatheesan. She graduated from medical school in India and did her neonatology fellowship at UCSF, excuse me. She started her career as a neonatologist in 2005 at Santa Clara Valley Medical Center, an institution committed to the medically underserved. She advocates for a comprehensive care model with a multidisciplinary team, including peer support mothers, psychologists, educators, and interpreters, along with the clinical team to promote family integrated care in NICUs. We also have Sangeeta Mallik. She's a developmental psychologist by training who oversees the peer support program in her family-centered care program for NICU families at Santa Clara Valley Medical Center. Her research interests lie in studying early childhood developmental outcomes in at-risk populations and strengthening peer support programs in NICU settings for family. Thank you both for your hard work. We're looking forward to your presentation. Take it.
Great, thank you, Morgan. I'll go ahead and share my screen. Can everyone see your screen and hear us? Okay, great. Thank you for that lovely introduction, Morgan. And thank you, Mallik and your team, for giving us this opportunity to share our work from Santa Clara Valley Medical Center. I am fortunate to have a great team here at Santa Clara Valley Medical Center, and today's presentation will be a combined presentation with me and Sangeeta. And really, it's going to be representing the work of our NICU as a whole. We're fortunate to have a great Santa Clara Valley Medical Center family-centered care team that includes Sangeeta as the director of the program. We have 3 great family support specialists, and I'm happy to see all 3 of them present today. Jennifer Godfrey is in the room with us, and I see Caitlin and Patty Meyer, who are also logged in to this meeting. We have a family education specialist, that's Erin Saucedo, and both Laura Burrito, who's also here today in this meeting, who's our NICU nurse manager, and myself as the director are very involved with are part of the FCC team. Our objectives, I want to start with acknowledging everyone that has been integral to our program here before the end of the presentation. So we're grateful for our families and babies who are born at Santa Clara Valley Medical Center, O'Connor Hospital, and St. Louis Regional Hospital, which are all the other sister institutions of our healthcare system. We have great NICU staff and maternal child healthcare team staff at Santa Clara Valley, O'Connor, and St. Louis, who are also been extremely helpful in providing family-centered care to all our infants in our institution. We have a great family-centered care team. We've been fortunate to have funding support from Valley Health Foundation from First 5 Santa Clara County and March of Dimes as well. The objectives of our today's presentation is really to describe our journey of family-centered care program at in our institution, and also highlight how the FCC team now is an integral part of our NICU care and decision-making. Before we move on, we are one of the safety net hospitals. So I want to describe what do we mean by safety net hospital. A safety net hospital is one that provides a significant level of care to low-income, uninsured, and vulnerable population. There's a commitment to provide access to care for all people with limited or no access to healthcare due to socioeconomic circumstances or insurance status or due to complex health conditions. From that description, Santa Clara Valley Healthcare System is really one of the safety net hospitals. The mission of Santa Clara Valley Healthcare System is to provide high quality, accessible healthcare and service for all persons in Santa Clara County, regardless of their socioeconomic status and ability to pay. One of our motto is, our healthcare system's main motto is to promote better health for all. We have 3 hospitals and multiple satellite clinics associated with our healthcare system. At Santa Clara Valley, we have a level 4 NICU. At O'Connor Hospital, we have a level 3 NICU. And at St. Louis Regional Hospital, we have a newborn nursery. Between all 3 institutions, we have a total of 4,500 deliveries, which covers about a quarter of the Santa Clara County births right here in the Silicon Valley. A quick overview of our NICU. We are a level 4 NICU. We have 300 to 350 annual NICU admissions. We are a 40-bed NICU. We have a lot of staff, including 6 neonatologists, 5 NPs. We have pediatric hospitalists, medical students, pediatric resident physicians who rotate through our NICU as well. We have a large number of more than 90 nursing staff. We have more than 15 respiratory therapists, lactation consultants, physical therapists, music therapists, as well, who are all integral to our function in our unit. We also get about 50 transports a year, mostly from our own sister institutions, but also from other local hospitals. Quickly to go over what do we mean by family-centered care in the NICU. I think for us, one of the main themes of family-centered care in NICU means, the parents or the family to be able to parent their child while the baby is in the NICU, which means the parents are actively participating in daily newborn routine care. They are able to provide positive touch and skin to skin, all the important neuroprotective strategies that are key to promoting optimal development of the newborns, and where parents' concerns can be heard, where their cultural preferences or family preferences are understood, and where they are recognized as important partners in the care of their newborns. Promoting shared decision-making model by really building partnership between the families and the healthcare team. Our focus is to decrease parental anxiety and stress level while the families are in the NICU, but also prevent or decrease PTSD later on, which has been shown in literature. Are also to improve family experience while they are in the NICU, and to improve families' long-term outcome by promoting early bonding and caring for their children. The specific goals for our family-centered care program was to make sure we have peer support for all our families, to have our family-centered care team be really reflective of our patient population, to have paid positions for our family-centered care team members, to have the team as an integral part of our NICU clinical team, and importantly, to secure sustainable funding so that we can continue this program in our institution. I'll hand over the presentation to Sangeeta. Before Sangeeta starts describing our program, I'll go over a little bit of the history of how we started, where we started, and where we are now. Our very early focus on family-centered care started in 2007 when the director and the medical social worker at that time actually submitted the application for March of Dimes NICU Family Support grant. And we were issued our March of Dimes chose us as one of the first 10 units that were recognized as NICU family support site across the nation. And the main focus of this grant was to promote family education, staff education, family-centered care, and improve patient experience. After that, in 2012, we were fortunate to hire our first family support specialist with extramural funding, who was to provide bilingual peer support in our unit. And in 2014, we were able to expand our program to hire our second family support specialist with primary focus on supporting our mothers with substance use disorder and or on maternal medication-assisted treatment programs who are in recovery.
X-ray in room 4 for doctors to please come to room 4 for X-ray.
Initially, in the early phases, so I almost want to think of our program as 2 phases. The early phase where we had, 2 family support specialists who were providing peer support and who were also working closely with the March of Dimes program with the guidance from the March of Dimes program coordinator as well. Later on in 2019, we were able to actually submit for grant monies to expand the program to include a dedicated leadership for the family-centered care program. Because what we realized is when in the early days of our program, the leadership, the lead of the family-centered program was either a physician, a neonatologist, or a bedside nurse, or a nurse practitioner. And unfortunately, because of our day-to-day responsibilities primarily focused on daily clinical care and at bedside, we felt like the program wasn't able to expand to meet the needs of our patients as much. And we felt that need for identifying a dedicated person whose only focus is family-centered care. And I think as you hear more about our program, our program went from having 2 individuals who are providing peer support with some activities to a really more comprehensive program, providing more support and being more actively involved in the NICU day-to-day function as well. So in 2019, we were able to hire our 3rd family support specialist. 2020, we had a family education specialist, and so on. So I will hand over the mic to Sangeeta.
Thank you, Priya. It's an honor to be present here to share our family support program with all of you. Without further ado, I wanted to emphasize the importance of peer support. As mentioned earlier, our family support specialists have walked the journey of many NICU families. And it's that, similar lived experience that forges a special bond with our families where it's a bond of trust. It's a bond of understanding, what another mother perhaps may have gone through. That is very critical in establishing key relationships between our family support specialists and our NICU families. I wanted to go a little more in depth about our team members. As mentioned earlier by Dr. Jegatheesan, our first family support specialist that was hired, Patty Meyer, is Hispanic, she's bilingual, and her baby girl, Jasmine, was born at 27 weeks preterm in our NICU. Patty has also experienced infant loss. She is deeply, deeply attuned to, what this particular population goes through, and has been a strong advocate for herself, as well as her family and other families in the NICU since day one. She was hired in 2012. One of the reasons also that we hired Patty is she knew she had experience in breastfeeding, a preterm infant. And that was also one of the reasons where we felt she was, in addition to so many different amazing qualities that Patty had and her empathy for this population, she was hired. A lot of stories are connected to each member of this team. We have only 30 minutes. It would take a long time to go through many of those stories, but I want to share one connected to Patty. Patty observed that we were doing skin to skin in the NICU, and one of the things she brought to the leadership is, why can't we have handheld mirrors offered to our NICU mothers whilst they did skin to skin? That would offer them the opportunity to actually take a look at their child, to bond with their child in what can sometimes be a stressful environment. And Patty was the one who brought this idea to our team. And so we bought handheld mirrors and offered it to our NICU mothers during skin to skin sessions. The next family support specialist on our team is Jennifer Godfrey, who's right here with us. Jennifer Godfrey is a former NICU mother. She had a 27-week preterm infant. And Jennifer had a history of substance use disorder and was in recovery prior to delivery. Jennifer is extremely passionate about providing support to other mothers with a history of substance use disorder. She has shared her experience with recovery programs in our county with many mothers. She has also toured residential programs for those mothers that were ambiguous about starting their journey to recovery. She was hired in 2019. And one of the key facets, and this applies to all our family support specialists, is that many a time our families stay in touch with our family support specialists well beyond discharge. A story connected to Jennifer that is extremely powerful is we had a NICU mother with substance use disorder that was at risk of losing her baby, and CPS was involved. And Jennifer had counseled the mother on several occasions about her journey to recovery. She had actually taken her to one of our, one of the programs, local programs as well. The mother at that point in time declined following that path and unfortunately lost her baby. Fast forward, little time forward, we found that this particular mother had delivered another baby in our hospital, and that baby was admitted to our NICU. And we found out that when this mother found out she was pregnant with this second baby, she had actually enrolled herself in a recovery program, remembering all the advice that Jennifer had given. So this kind of is a story that comes full circle in describing the power of connection and having a family member truly understand and feel trust from a family support specialist. It's a story that will stay with us for a long time. Our third family support specialist is Caitlin Evans. Caitlin Evans is also a former NICU mother. Her baby girl Dahlia was a 24-week preterm infant who was born in our hospital and admitted to our NICU. Caitlin has been a very strong advocate for maternal mental health support. In fact, we had a nursing conference a few years ago where Caitlin basically impressed so many of the attendees by sharing her story and emphasizing, how she got the support that she needed vis-a-vis mental health. And she is extremely passionate and has been known to share her story with many NICU families around this particular topic. She was hired in 2022 as a family support specialist. Caitlin is incredibly creative. She has created skin-to-skin brochures for our NICU staff. She's been involved with the other family sports specialists in kangaroo-thons. She also chaired last year our NICU reunion that occurred 3 years after no reunions, and we're lucky to have her. A particular story connected with Caitlin is how she supported a NICU mother who was struggling because that particular mother's baby was very ill. Unfortunately, that particular baby passed away. And a few months down the road, that NICU mother reached out to both Caitlin as well as Dr. Jegatheesan, asking for resources to help her vis-a-vis her mental health. And it, once again, is a story that comes full circle in terms of that bond, that connection and the trust that families feel when they get support from our family specialists. So to summarize the wide range of activities that our family support specialists do, they typically try and meet our parents within 2 to 3 days of NICU admission. At that point in time, they introduce themselves and share, if they can, a self-care packet with our families, as well as booklets around NICU stay. They try and communicate with our families in person or by phone 1 to 2 a week. If the family is comfortable, our family sports specialists attend family conferences with the medical team to provide support to them. They also administer family satisfaction surveys, and this satisfaction survey is administered typically 6 to 7 days after a baby is admitted into the NICU. So it's kind of an initial pulse on how the family is doing and how they feel supported, how well they feel supported by our NICU staff. And the survey is also administered around discharge time. Our family support specialists make themselves available to support our families even when their infants are critically ill or dying. We have organized days of remembrance with the blessings of our families, and have known to be present there to provide support during a very, very difficult time for our families that have experienced loss. And as mentioned earlier, they do a great job of staying in touch with our families post-discharge, as and when the families feel like reaching out. My role as the Director of Family-Centered Care is to create an environment where there's structured communication within our team. Our team meets on a weekly basis to discuss a range of issues concerning our NICU families. When necessary, we escalate any kind of problems that may arise as communicated to us to our leadership. My job is to bring in a level of accountability vis-a-vis my team. I often communicate between our team as well as NICU staff about our work, the various range of activities that we're involved in, so people know on a pretty regular basis what the FCC team does and how it supports our families. Thank you. I'm also responsible for disseminating information to our NICU leadership. And my role is not only to improve communication, but is to expand the breadth of services that we offer both within the NICU as well as outside. It is basically to build a program so we have more visibility and people know about our work. I'm a developmental psychologist by training, and on a personal note, I experienced loss at 23 weeks in my pregnancy. I joined the team in 2019. I'm extremely passionate about serving our NICU families here at Valley Medical Center. We have our amazing family education specialist, Erin Saucedo. Erin Saucedo is charged with providing education to our family in a non-stressful environment. She invites them often to our conference room on a weekly basis and teaches them about baby care, CPR training, facets of discharge teaching. But one of the most popular and amazing classes that Erin spearheads is the scrapbooking classes. Week after week, families come together in our NICU and create memories in their scrapbooks by bonding with each other, as well as with our NICU staff and family-centered care team. And this is something that, Erin has done an amazing job with support as well. Patty often supports over our Spanish-speaking families, and we're very proud of that. The basic idea is to promote connection in a supportive environment, a less stressful environment. Erin Sangeeta, by the way, is a former NICU nurse, and we were privileged to have her join our team in 2020. I'd like to talk a little bit about the challenges our team faced during the COVID-19 pandemic. At that time, it was very clear to us that we as the FCC team could not meet our families in person in the NICU. The policies around parents visiting, and I use this term in quotes because in our minds, our families are not visitors, but obviously there were constraints in terms of the number of people that could come and spend time with the babies. It became much stricter in the NICU during the pandemic. Translation support was also not offered in person, and our beloved scrapbooking classes were put on hold. The way we pivoted during this time is we decided that we would connect with our families via phone every week. And when it became all right for us non-essential workers to be allowed in the NICU, we tried to meet the families once a week in person. We did a pretty great job communicating the changes in visitation policies with our families. And they went through several changes over the course of the pandemic. So we would keep all our families abreast of these changes, and sometimes even advocate on behalf of many of the families that were dealing in special circumstances. One of the key issues that we have advocated for relentlessly in the NICU is to provide support to our families that have, that are non-English language or of non-English language preference. And we have advocated for phone as well as iPad translation services being offered to those families. Our on-site parent education classes led by Erin ended up being held twice a week following social distancing guidelines with masking during the pandemic. What we do with our NICU families is we attempt to change the nature of their family experience in what can be a very stressful journey by sharing lived experience, by providing them with encouragement, emotional support. What our team does is essentially let them know that there are staff members here that are here to support you every step of the way, although the journey may look scary and frightening oftentimes. We do several activities to enrich the family experience in the NICU, and this is a list of many of them. We organize holiday family activities throughout the year. We host picnics for NICU staff as well as our family members. We plan annual NICU reunions. We offer weekly scrapbooking classes for our families. I'll talk a little more about the Wall of Hope, which is an amazing source of inspiration for many of our NICU families, where we have the story of a NICU birth and how a baby survived and thrived through their journey in the NICU. We have these stories adorning the walls of our NICU as the Wall of Hope. We participated in readathons as well as kangaroo-thons to support our NICU family members. And here are some pictures. A picture speaks 1,000 words. And these are some of the activities that the FCC team, has organized for our NICU families. As recent as, end of last month, we had a New Year brunch for our families where they got together and, with other staff members and relaxed and bonded with each other. We have holiday activities around NICU families. Patty Meyer is so talented. She produces the most adorable, creates the most adorable onesies with, different holiday decorations. Each family member was provided a onesie for their baby. We had family members creating gingerbread houses. This was in early December. And you could see the happiness in our families in getting away from the stress and bonding with each other, opening up to NICU staff. Here's our Halloween celebration picture that we had earlier last year. We threw a Mother's Day tea party for NICU mothers, got them away from the bedside, gave them treats. They connected and learned from each other. Valentine's celebration, once again, adorable onesies were created, lots of arts and crafts for our families were offered, and treats. And the NICU picnic that we had held right outside our grounds here in the hospital for our family members as well as staff. I'm particularly proud of talking about our NICU reunion that was held August 26th of last year. This was a reunion that was held after 3 years of no reunions. I'm also would like to mention that we collaborated beautifully with the nursing team at O'Connor NICU, were fabulous. And Caitlin Evans chaired this particular initiative, but got lots of support as well from NICU staff here at VMC and our family center care team. We had over 300 attendees join us that afternoon, and there were all kinds of activities, soft play areas, there was face painting, there was music, a petting zoo. And you can tell that families just had a great time connecting with each other, seeing the nurse that looked after their baby once they were in the NICU, or wanting to talk to the neonatologist or the family support specialist that held their hand through this journey. Here's a picture of a NICU scrapbooking session in our conference room. One of the things that we, as mentioned earlier, that we have done is provide also emotional support to our families that have experienced loss. This particular picture is from a Remembrance Day that the FCC team had, basically held in honor of a baby that, a mother that basically lost her baby. And you can tell it was a very emotional experience for the mother. This was planned in conjunction with the mother's advice, and both the parents as well were in attendance, and their families, as well as NICU staff. There were doves that were released. It was a very solemn yet beautiful ceremony to remember the special soul in this particular instance. So I wanted to make sure that, people knew that we offer this as well, if the family is amenable to it. This is an example of our Wall of Hope. This particular write-up is about Jaslyn Meyer, Patty Meyer's daughter. We worked in collaboration with the March of Dimes to create write-ups of the amazing journeys that our NICU babies have been through. And these particular, stories adorn the walls of our NICU. The hope is, as parents walk through our NICU and they read these stories, that they are filled with support and hope for their own journey, for their own particular child's journey. And so this is something that we're extremely proud of. A lot of work went into creating the Wall of Hope here at our NICU. In addition to all the support we provide our families directly, we participate in NICU clinical and QI work as well. For example, we attend clinical rounds and multidisciplinary rounds on a weekly basis with the rest of the NICU staff. We liaise regularly with our NICU social worker to support our families, and in a very timely way, family feedback is provided to medical staff as and when we get feedback from families, or there is a particular family that reaches out to us sharing a particular experience that we need further support with. I mentioned earlier about our satisfaction survey data collection. We consider the voice of the NICU families in a sense. And we've supported staff in creating skin-to-skin brochures, readathons and candle-a-thons, as mentioned earlier. In terms of the work we do vis-a-vis unit improvement activities, we, as mentioned earlier, have really helped NICU staff address language barriers. Knowing the population that we serve, it was very important to us to advocate on their behalf. Also, another issue that was of importance is addressing the education needs of our families and spotlighting them to our NICU staff. We have many families that do not read English, they do not understand English, or for that matter, may not even know how to read. How do we address information exchange in those particular scenarios? I'm proud to also mention that this year we established our NICU Family Staff Advisory Council. We have 7 NICU family members that graduated that are part of this particular council. We also have several NICU staff members, and we meet with them every 2 months or so to glean feedback on how to ameliorate the family experience for our NICU families. And we also, educate staff on appropriate ways to communicate with and about our NICU families, understanding the trauma that they've been through. Another issue that was also brought up was the importance of providing daily updates to our families. In 2022, we established a Voice of the Patient panel to engage NICU leadership, to raise awareness around the gamut of the family experience. And the idea was to create a culture of respect for our families. We had 3 former NICU family members that connected with the FCC team over a couple of Zoom calls. And they are the ones that gave us feedback over the exchanges that we had on how to address language barriers with NICU families, as well as keep families informed and get regular updates from providers. We're also involved in staff education. There's the informal education piece. We remind clinical care team of the trauma. We advocate, for non-English language preference families, and also ensure that when, documents are provided to our, families, is it appropriate given, their struggles, with the language or their education levels. In terms of formal education, we share educational videos on trauma-informed care, the family perspective, as well as staff burnout. We are so tuned into how hard our NICU staff work in the service of our families and our babies. And I think the most important thing is to understand that it's okay to say that, address issues like burnout and talk about it in a safe setting. And of course, the satisfaction survey reports is something that we also on a regular basis update our NICU staff about. Aside from all the work we do in the NICU, we are engaged in a community of learning outside of the NICU. We have traveled to several conferences, such as Vaughan, Cannes, Ravens. We participate in statewide collaboratives. Jennifer Godfrey is a member of the CPQCC Family Advisory Council. We are part of this amazing group, the FCC Task Force as well. We regularly attend and provide our feedback. And both Jen and Patty, part of the CPQCC subcommittee, where they have, actually shared, the work groups, how they support non-English language preference families, as well as support mothers with substance use disorder. Here is a screenshot of Jennifer's video that was included in a recent March of Dimes brand rounds around breaking barriers for burnout, strategies for supporting NICU staff. Jennifer shared a very moving story of how she was so well supported by Patty Meyer when she was a NICU mother. And in a sense, that support, encouraged her to reach out to Caitlin when she saw, Jennifer was, after discharge, was visiting our NICU a few months down the road, and she saw Caitlin, whose baby had just been admitted into our NICU. She reached out to Caitlin to support her. And it was, a lovely snippet that was shared in this particular brand rounds. This is a playful, slide about our 3 amazing family support specialists. This was an award that was given to Caitlin, Patty, and Jennifer last year by the March of Dimes for being the most creative in the way they support our NICU families. And I cannot speak enough to how talented and compassionate and amazing, these 3 family support specialists are. As a team, we also need training. We need our skills to be upgraded as well, given the work that we do. So the FCC team has been trained on customer service internally in the hospital. We get a lot of information from our family support specialist, who is part of a family advisory council. She's a member of the CPQCC Family Advisory Council, so Jennifer will bring back information to us. It helped us create an amazing Family Staff Advisory Council itself. And we also have offered training to be a patient family partner to our team, family support specialists. And now I'll hand over the baton to Priya to talk about family support.
I want to keep a quick, how many more minutes do we have for getting Mallik?
So I believe we had you slated to speak until 2:45, but we can certainly give you another 5 minutes or so if that would be helpful.
Great, thank you. So I'll quickly,
Thanks.
one of the things that we're often asked is when we share our work, like, how do you do all this and what is the funding support? I think key is building partnership with your foundation, if you have a foundation associated with your institution, but also reaching out to other nonprofit organizations who may be available for support in your county or in your city or from state. So our funding actually started, the March of Dimes NICU Family Support Grant application was not necessarily to fund a position, but it started with in-kind support application where they were giving us all the booklets and some of the materials to support our families. And also there was a kiosk that provided some family education that was given to us as part of this fund. In 2009 was our first grant that supported Patty's position, and it's from our first 5 of Santa Clara County. And it's a nonprofit organization, and we shared the same vision and mission, so we were able to apply for the grant. And this grant gets renewed mostly annually. Sometimes we can go for a 3-year period as well for renewal. We actually continued, and many of our work, like the expanding the program, really came from showing, what it meant for our families, the support that our FCC team provided. So over the years, we were able to really secure more and more funding to include the third family support specialist for the director role and for our education specialist in 2020. Now, just like any funder, anytime you get extramural funding, one of the things is it comes with, providing them with information that that says that their money is being utilized in a valued way. Now, for a program like family-centered care, it's hard to have like an outcome per se that is easy to show, but we have we submit data quarterly and on annual basis. Some of the data is process measures, really showing like how many families were supported by our FCC team. We have a neonatal abstinence syndrome report where we actually tell them how many babies are born exposed to substances in our system, how many are admitted to NICU, and so on. And then we do provide success stories. I think the qualitative information that comes from our families sharing their thoughts on how they were supported through the FCC team has been also very powerful. And then we have our regular satisfaction survey that we submit. Demographics report, for our funder here, they are keen on, what zip code our families are, which families are we supporting. So we provide the race, ethnicity, zip code, and the language of our families that are supported. And this is an example of our NAS report, essentially showing how many babies were born who were exposed to substances, how many of them are admitted to NICU, what % of NICU admissions were exposed to substances, and what kind of substance they are exposed to, and so on. And the success stories includes like quotes from our families. This is one quote from a 25 weeks mom that said, after my experience at the emergency department at the other hospital, I felt rejected and traumatized. And this is her speaking about one of her previous experiences. After talking with you, the nurses and the staff at this NICU, I felt so much better. And this was a quote that was given by a parent to one of our family support specialists. And this is a family satisfaction survey that has 12 questions asking about how were you treated? How was your front desk staff? How did they talk to you? Did the nurses keep you included in the care of the baby? How did the doctors treat you? Did they show respect to your preferences? And so on. And our goal is to always have very satisfied answers. And this is something, again, the FCC team administers this survey because we feel like the families are more open to sharing their true thoughts to the FCC team, and they compile this information and present it to us on a monthly or at least a quarterly basis. future directions of our program, I think, our team, based on the voice from the Family Advisory Council, they are going to work on a welcome video for our families. We are really focusing on formalizing some of the staff training for our FCC team. All our peer support specialists are interested in going through the lactation educator class, which I think would be amazing for our families. NICU peer mentor program training is something we're looking at to help have our staff go through that training. And one of the biggest tasks that we are now working on is really converting the grant-based roles that our family support specialists are now on, or the whole team is on, to convert them to really coded positions or county hired positions so that they become integral part of our NICU, just like how, we have the institution hires nurses or doctors. We want the FCC team to be an essential worker, not a non-essential worker that's dependent on external funding. So that's really our future goal, and hopefully we'll get successful. So take home message for us from our program is, peer support is free, leadership buy-in is essential, and really working on funding support for paid positions for a safety net hospital, because our families can't afford to come back and volunteer their time. If we think this role is so important, we need to make them funded positions. Program building, we do believe that you need dedicated staff who focuses only family supports, family-centered care, because I think when our experience from having either the director or the nurse or the neonatologist or a nurse practitioner, we all have so many other responsibilities. The program doesn't get the necessary attention that it needs. And it really, I think our team now has shown us we can do so much better for our families as a whole team than, our traditional model of clinical team working by themselves. Integrating the whole FCC team as part of a clinical team is essential. We want to make sure we always have the voices of the NICU families heard in all our meetings. And the QI activity, really now, most of our QI activity is informed by our FCC team as well. This is a quote from Jen. The memories of this place and what the staff did for me truly hit me 6 months after discharge, when your baby is hitting their milestones and they are starting to become healthy. You look back and realize how much hope the NICU gave you. The stories that I heard from my family support specialist and other mothers, and the encouragement that I received from the NICU staff was so profound when I got to the other side. I realized how much they carried me through that time when I was in the NICU. So this is Jen's quote. And again, we are so fortunate that now Jen has come back to be a family support specialist. And we've learned a lot from each and every one of them, Patty, Caitlin, and Jen. Thank you.
Thank you both so much. What a touching presentation. It's really neat to see how you celebrate your NICU families. And there are a ton of questions in the chat about how these principles can be implemented into others' local centers. We'll go ahead and collate those for you both and send an email post-webinar with your answers if possible. I'm going to go ahead and hand it right over to Colby to introduce Gaby. Gaby, would you like to share your screen during your introduction?
Sure thing.
Thanks,
Morgan. I'm Colby Day. I'm one of the co-chairs, and I'm excited to introduce you to our next speaker. Gaby Cordova Ramos is an implementation scientist. Her research investigates the translation of evidence-based interventions into practice to reduce racial, ethnic, and linguistic disparities in neonatal perinatal delivery of care. Gaby, it's all yours.
I'm actually having trouble sharing. Give me 1 second. Let's see. Any chance you can share my slides? For some reason, it's not letting me share them.
I absolutely can. Just a minute. Let me get that pulled up for you. Let's see. I believe it would be, I have it right here, just a moment.
Thank you. New laptop, first day using it. Apparently I have to go to systems preferences to allow Zoom to share my screen. So something like that.
Oh, sure, no problem. And I have your presentation right here, and now I'm having trouble getting it up. Just a moment. I'm so sorry.
No worries. So sorry. Let me see if I can quickly update these.
Okay.
While we do that, I will do my quick disclosure. Like, we're definitely gonna talk about the experience of our own unit, but this is in no way my way of saying this is best practice when it comes to social determinants of health screening and referral, because we're still learning a lot, especially as we incorporate and disseminate the practice across other units in our state. So this is just the way we chose to do it, incorporating family voice and staff input. But we are welcome to hearing how others are doing it and learn from you as well when I do share our processes.
Okay, here we go.
Awesome. Thank you so much. All right. So I will, please keep me humble with time. I will try to go at a slight fast pace because I am trying for this talk to be really practical. So there's a lot of examples. So I'm going to try to go through a lot of content in the 30 minutes. This is a very brief introduction. I just wanted everyone to be on the same page that social determinants of health, adverse social determinants of health, are extremely common in the preterm population. Looking at national data, we showed that not only are preterm infants more likely to be born in low-income households, but these families in low-income households are also 2 to 5 times more likely to experience hardships such as food insufficiency, financial hardship, and difficulty paying bills. Next. And this is extremely important because these hardships are strongly associated with poor health, medical conditions, hospitalizations, ER visits, foregone healthcare, and a number of adverse child and maternal health outcomes. Next. So in the NICU in particular, our families are with us for like weeks to months at a time. And a lot of this work to identify and address social determinants have really focused on outpatient care. And in the NICU, we just have this unique opportunity to have multiple touch points with families. And so the fact that this hasn't yet expanded at scale in NICUs is kind of astonishing. And in particular, these hardships for NICU families impact direct evidence-based practices, such as breastfeeding and skin to skin. And these are just some quotes from the families in our own unit that kind of illustrate that point. One family said, during the time that we were in the hospital, we were barely making enough money because I wasn't working. There's so much you have to pay for. Parking every day, food is also expensive. We fell behind on rent. I was sad and stressed. I couldn't make any milk. And another family talks about being unable to drive because of C-section and the pain and the swelling, not being able to get a ride to go to the NICU, and then eventually that leading to breastfeeding discontinuation. Next. And this is an excellent article by Lewis and collaborators that just is also a qualitative study of barriers to being present in the NICU. And one of the main barriers they identified was, of course, adverse social determinants, transportation issues, housing instability, parking, childcare, like many mentioned before in the previous presentation. Next. So, of course, this has been in guidelines for a very long time, like the AAP poverty statement is dated back to 2016. But most recently, payers are also mandating social determinants of health screening and referral. So there's a newly kind of like a new environment, a new regulatory environment in which units are approaching this topic. Next. So I just wanted to show these most recent regulatory requirements because many units have approached us kind of like to share our experience implementing it because they are now mandated to do it. But I want to draw your attention to the one from the Centers of Medicare and Medicaid Services, which is now mandating in 2024 to incorporate the measure of screening for social drivers of health. And they focus on 5 domains, which are food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. And they want this measure for all patients who are 18 years or older at the time of admission. So something that had originally been exclusively in outpatient world is now moving into the hospital. And that has a lot of implications for the NICU, because our patients will first go to the ED and then to labor and delivery and then to us. And so it has to, like, we just have to think of how families experience all of that until they get to us. Next. Okay, so very brief context for those who are not familiar with my unit. We are a level 3 NICU, an academic urban safety net hospital, about 2,800 birth, and we're a 22-bed unit. We serve primarily publicly insured families or uninsured families, and we have a lot of diverse families from racial and ethnic minority groups, and a good number of families who speak languages other than English. Our particular unit, before we started this work, had a really terrible social work FTE, just one social worker, one person, covering NICU, labor and delivery, and postpartum. This has changed, and part of the change was advocated for by our group with data that we collected during this time. And so that's one of the many benefits of engaging into this work. Now we have more social work FTE. And of course, like in many of your units, most families, if not all, see the social worker. Next. All right, so I'm going to go to the practical part. So I'm going to try to walk you through kind of like what we did and how we did it, from the time we selected and adapted our tool, then how we gathered some stakeholder input for the processes to put the screening and the referral in place, how we implemented it, and then what are we measuring and how are we iteratively adapting and improving this work. Next. And I'm also not terrible at reading the chat at the same time that I talk. So please, if there's a question that would be best answered in real time, I can definitely do that. All right, so the screening tool selection and adaptation. Next. All right, so this is going to be, Morgan, if we can just click through it, just like the whole thing, it's going to be probably easier. Okay, perfect. So when we orient the teams in our state as to how to decide on a tool, the first thing to know is that there's no evidence that any tool is particularly better than others. So what we tell teams to think about is, what are you mandated to ask? So in this case, CMS mandates. What is relevant to your NICU population, and what resources do you have for positive screens? And so depending on that, you'll decide what to ask. So the first 4 domains, housing, energy, food, and transportation, are again CMS mandates. And those we highly recommend to include in your screening because they are, 1, very associated with child health outcomes, and 2, just really important things for enabling participation in NICU care. And the same is with childcare. And then the issue with childcare is linking it to helpful resources. So that's going to be variable across units, of course. Then employment and education are not mandated, but our unit in particular chose to include it because they are so tied to economic mobility of families in the long run. But we ask these particular domains at the household level, at the family unit. If the resources are not relevant for the birthing person at a time, they may be relevant for the for other caregiver in the family unit that it ultimately impacts the child. Material goods for babies, again, really important, but again, need to be tied to resources. Interpersonal violence, it's the 5th mandated domain. And that one, it's of course extremely important. But in our particular unit, we chose not to include it in the NICU because it is universally screened for in labor and delivery. And so it is something that social workers assess on a regular basis, but in the way we do the screener and the way it happens, it didn't feel that it needed to be repeated. And then internet, something to consider, because most recently there are like pretty notable, after the pandemic, there's like pretty good resources out there. Next. All right, so this is our original tool. And I'm sure you'll have access to the slide so you can see the detail of how it evolved. But this original tool was developed in 2017 at BMC for the adult outpatient world, and then eventually went into the pediatric setting outpatient. The benefit of using a tool that is already within your health system is, of course, that it's likely already integrated into the electronic health record, and most providers will be somewhat familiar with it. In general, we love tools that assess for both risks, so things like food insecurity, but also for need. So if you do have food insecurity, are you interested in receiving resources now? So that is what we call social need, like kind of like families, like self-assessment of wanting resources. Next. Of course, there were a few things that didn't quite fit the NICU context because they were designed for adults. So we can just click through the next couple. Oh, sorry, the previous one. Yeah. So things like, do you have trouble paying for medicines? Do you have trouble getting to your medical appointments and things like that? So I'll show you how we adapted them. Next. So we did a couple of focus groups with families, one in English, one in Spanish. They were actually really successful meetings, and families really engaged in giving us feedback. Didn't hold back to tell us things that didn't work for them. And then we also held some regular meetings with the whole NICU team. And the idea was not only to review that tool itself, but also to walk through the actual process of screening and referral. And then once we had a revised tool, we tested it at the bedside. Next. So this is an example of how we adapted one of the questions. So for transportation, for example, the original question was, do you have trouble getting transportation for medical appointments? And then some of the feedback we received was like, I don't really like the phrasing, do you have trouble? Maybe offer support instead of asking for trouble. And then very strongly, many families felt that we have to explain what we're going to do if they do have transportation issues. And so we rephrased the question to ultimately be, do you need support getting transportation to or from the NICU? And then we put examples of what we were able to offer. Paying for parking, getting a taxi ride, shuttle services. And this is, for example, in our unit, parking is not free and it's not for everyone. And so we had parking passes that were limited. So we had to like give it to families that had the screening positive. Next. Similar to employment and education, we rephrased it to also include other members in the household that will be directly involved in the infant's care. So do you need support looking for a job or job training for you or anyone in your house? And the next, for education, similarly, we, like the original question was really vague. Are you interested in more education? Which is like, we had an enormous number of yeses when we first like had that question, but families didn't really understand what that meant. And so eventually we made it more clear and also linked it to examples of what we were specifically offering. So do you need support getting more education for you or anyone in the house? For example, obtaining a GED and English as a second language classes, which were a particularly popular resource. Next. So this is how our adapted tool looks like now. So we'll go through the process of screening later, but we ultimately decided to do it in a verbal format. So actually there's a primary bedside nurse or a peer support specialist who conducts the screening with the families with whom they have already established a relationship with, and they introduce the screening with this verbal prompt. So the first, next. So the first element of our process is to have this disclosure statement, which can be either the verbal prompt that we have or something written if the screening is given on paper, for example. And the important elements of the disclosure statement are things like why we do this, the fact that it is universal for our families, the fact that it is voluntary, and some element of what to expect after completing the screening. Next. So the other thing is to target the household, particularly for things like employment and education. Next. And then including both social risks, in this case, the hunger vital signs questions for food insecurity. Next. But also social needs. So kind of like those things that families consider like want assistance for. So do you need support with? Yes or no? And then very, very many families like strongly felt that we should be very specific about what we would do after a positive response. And so we have examples of the resources that are available for a given question. Next. So in general, there's no perfect tool. So the whole point is to choose a tool that is brief, relevant to NICU families, and that meets the regulatory requirements that you have. But at a minimum, considering including food insecurity, housing instability, utilities, and transportation. And if deciding to include education needs, English as a second language classes have been particularly successful. Next. So how we implemented it. Next. All right, so this is how the process has started. Since then, it has evolved a little bit more. This is also available in our pediatrics paper from 2023, so you can like read the more detail. But the screener happens by a primary bedside nurse. And I'll walk you through the decision of the social worker not doing it originally. So the primary bedside nurse determines eligibility, which is basically any family that is expected to have a length of stay greater than a week. And the reasoning for that is because this happens at the outpatient setting. So if we have a baby that's going to be 24 hours in the NICU for hypoglycemia and then go to the PD the next day, it doesn't make sense. We don't have time to also kind of like help connect with resources. And so we decided to do it for families who stayed greater than a week. We attempt to do it within the first 2 weeks of admission, but not at admission. And the only reasoning is for feedback from families that it is an overwhelming timing where the questions feel lost. And they are not necessarily thinking of what they need, and it could evolve, the needs evolve over time. And very controversial because now that we're implementing it in other units, many units feel that there's likely a higher likelihood of families disclosing more needs when they do it individually as opposed to when someone asks. But we decided to do it this way from feedback of both families and staff that when you have established a relationship with someone, there's an opportunity to ask these questions and phrase them in a way that can facilitate disclosure of needs. So for example, asking about transportation when the bedside nurse does it is like, I love that you came here. Like we ask about transportation to all families because it is so important that you're here. You know, so it can be linked to a medical thing. It can reduce the stigma. It can make it easier for families to disclose a need. And so that's why we decided to do it in a verbal format. There's some evidence from the adult world that doing it like when a family completes it on an iPad or on a paper, the disclosure rates are higher. We don't have that level of data from our NICU population, but this is just how we do it. And then for the referral part, we both provide a resource guide, and the nurses communicate with the social workers. So if it's an urgent thing, that can be a page. And of course, first they know whether the social worker is already aware of the issue, for example, homelessness, which is a good example. And then not urgent things such as like the families interested in English as a second language classes are just discussed in the weekly social work rounds. And then the social worker is the primary responsible of following up with the family, helping them walk through the process of the referral, and then troubleshooting barriers to connecting with the resource. Next. I always like to pause here because like we are one of the few units where the nurses do these, and we get the question all the time of like, how did you get your nurses to do it? Or like, why didn't the social worker do it? Because it's such a social work thing. And so we in particular had very limited social work bandwidth, and social workers in general just care for an array of highly complex issues. And next, we strongly feel that a standardized screening do not ever replace the essential role of social workers, but it can definitely help streamline their processes, and it can even make it so that because they're dealing with so many things, nothing gets missed. We did do some work kind of like looking at social work notes from 2 of our units in our state. And without a standardized process, there's wide variability in the domains that are assessed, at least per documentation of social work notes. So this is just one way to facilitate the work. Next. So then we created our resource guide, and this is just kind of like our step-by-step. But we didn't want to reinvent the wheel, so we definitely gathered some resource guides from pediatrics and kind of reviewed what resources they were including. Then we used search engines like Find Help to look up any new resources. Next, we importantly, we importantly call every single resource that we include in a resource guide. And that was really important for us to experience ourselves. Wait times, kind of like general willingness of the person on the other side of the phone to engage with families. I called in Spanish to make sure like families with languages other than English could access the resource. And so it was really important for us to like try to like put ourselves in the shoes of someone that's going to call. And to manage expectations of families. Then we chose what to include and developed the information sheets and translated it into the languages that we serve. And then the next step is every 6 months, the resources get revised. And then we continue to improve it based on family feedback of what was helpful and what wasn't. Next. This is if everyone is going to have access to the slides. I'm just going to skip these because these are just some of the resources that we used. But this one is an example of our original resource guide. So we first decided to just have a one-pager with every domain and every resource there. So at the top, we included wraparound resources, so kind of like community action agencies that served a wide variety of services. So housing, rent, food, utilities, things like that. And we included, of course, contact information, hours of operations, and things, and anything the family and eligibility, general eligibility. Next. Then we also chose to include resources that we weren't necessarily screening for, such as substance use lines or domestic violence resources. Next. And then as the work evolved and we built partnerships, then we included things like the direct contact of the person who's going to receive the referrals from our site, or QR codes that allowed families to fill out applications or book appointments with the agency to streamline the process of connecting with the resource. Next. And now we have moved to single domain guides. And the reason we did that is because it allowed us to kind of like not overwhelm families with a lot of information, but also like just put a little bit more about each resource. So they look like this. This one is for housing. We include the same information, kind of contact information, eligibility, general resources. But then we have a section next for how to use this guide, which walks through setting expectations and how to like contact the agency and what to expect. And then also another section below next for additional helpful resources that include one of those wraparound resources, and also some kind of financial services from the hospital or things that may be of help for the family. Next. So in general, every single process that we do, from administering the screener to providing the referrals to following up on what was helpful or not, has to balance being family-centered, kind of like fostering trust, minimizing stigma, making sure that it is done like making families feel respected and dignified, but also doesn't burden the NICU staff, who's already like really busy and there has a lot of things to do. So we try to minimize time documentation burden and like just in general, make staff comfortable and knowledgeable about administering these things and talking about these things. Next. So a lot of it has been kind of listening to what families had to say about this. And it was really, really important for us to hear things like, I really don't want this to be asked because I have had really terrible experiences with social services, or I feel that if I say that I don't have a baby crib, I'm going to be seen as a bad parent, or that someone will call CPS if I say that I don't have a house, or simply that I will just say that I need something and you will not help me. And so those things were really like, we were really mindful of the fact that resources are never perfect. And so that is just something that really needs to be at the center of this kind of work, because if this ends up being a dead end for families, that just can kind of harm the relationship. Next. So these are some of the things we used. So I call them, I am an implementation scientist, so I really like to use the lingo of implementation strategy. And that's basically how you get people to do the intervention or the thing you're interested in implementing. So one of the things, some of the things we did are involving families really throughout. So we did a lot of background work before we did the first screening. There was a ton of work with families about how we were going to do these. And then families continued to be part of the process throughout, and not necessarily formally, but even like we trained the staff to like constantly check in on how things went. So if I screened on a Monday, then next time I see you, it's like, hey, did you have a chance to call? How did that go? And then we learned very quickly within a month, for example, of having started our first resource guide, what resources families really hated and what resources were really awesome. And so those type of things were really, really important, because as the staff saw that we responded to that feedback in a timely manner, they got more bought into the intervention itself. Then identifying and preparing champions is always important. That comes from QI a lot. And we had like 6 champion nurses in our unit of 63 nurses and 22 vets. Next.
Gaby, we've got about 5 minutes left.
Okay, so I'm going to rush.
Sure,
So
no
the disclosure statement we already talked about. Next. Staff training we did in various ways. So in the cases where social workers are conducting the screener, it's still really important to have all staff educated on this. And in our case, nurses had training in trauma-informed care, in empathic inquiry, and then we did a lot of dynamic role play. Well, like they had a script of what the family needed that the nurse that was administering the screening was not aware of. And then they went through kind of troubleshooting fears of disclosure and things like that. Next. We did a ton of PDSA cycles. Next. Particularly the first ones were just to integrate the screener and kind of like making sure it worked with the workflow. But the most impactful ones were the later ones where we kind of improved the resources and applied for some funding to expand what we could offer after positive screens. Next. This is one of our most successful cycles. So we applied for a $100,000 grant that allowed us to expand our screener capacity by hiring a peer breastfeeding counselor who then also got trained in conducting the screening and had the ability to work collaboratively with the social worker to do navigation services throughout the NICU hospitalization. So helping families fill out applications, call agencies, following up, gathering documentation. So very hands-on support. Next. I'm going to skip all the EHR stuff because that's a talk in itself, but it's in the electronic health record. And then we do a lot of outcome, collect a lot of data so that we can feed back to the staff how things are going. I'll show you some of that. Next. And the partnerships were crucial. And a lot of those started with those cold calls while we were gathering the resources. And just kind of saying, hi, I'm a neonatologist. I'm starting this process at Boston Medical. I would love to talk to anyone who could like give me a sense of what resources you have, what processes families go through, who's eligible, and whether you guys are interested in kind of meeting and collaborating. It was amazing. Like two agencies really like leaned in, and they provided personnel for warm handoffs. They provide feedback of the outcome of the referrals, and they presented in webinars and trained the staff, and it was really nice. Next. These are like the examples of the community partnerships we have with, but some of them are just community action agencies or JVS is employment, and Vital Village is kind of like a general post-breastfeeding discharge support, post-discharge breastfeeding support. Next. And this is really important. Like a lot of this work starts with extramural funding, but it gets things going. So when we first started asking about transportation, we could only provide parking passes and maybe a few Charlie cards. And then as we had numbers that showed that transportation was such a huge issue, we were able to apply for funding to establish what we have now, an Uber Health program. Next. And so definitely make the processes that feed your NICU context, but make sure they also prioritize the tenets of family-centered care. And some of the things that worked really well for us was the standardizing procedures to normalize the screening, being very transparent with families and staff, and ongoing education and training. Next. Okay, very quickly. I'm going to skip that. But I know what I was asking about how to measure things. So there's very structured ways of measuring feasibility, acceptability, penetration, and equity. So what I highly recommend is like stratify all your measurements by race, ethnicity, language, so that you make sure that your efforts are like impacting different groups equitably. Next. These are just some qualitative quotes. We'll skip. So these are our outcomes. There's just 3 slides. So basically, we increased our screening rates from nothing because we didn't have standardized screening to 49% and then 86% most recently. Next. But we're most proud of our ability to measure connection with resources, which increased over time to 71%. So there's still lots of room to improve, but like really good. So our lesson learned there next is to just be really thoughtful about data collection from the beginning. If things are integrated into the EHR, that can be particularly helpful. And it can allow you to identify and address inequities in implementation early on. Next. All right, so things that happened afterwards, and there's like literally 2 slides left. So hopefully we can do it. So one, hospital leadership expanded social work FTE, which is something we're like extremely excited about. That had literally just happened. The peer counselor, social navigator role was so successful with families, and we had such a strong data to back it up, that it was incorporated as one of the pilot value-based care programs hospital budgets, and is no longer grant dependent. And then we are continuing to work on like a specific thing. So right now we're like measuring a different way of providing transportation assistance, and whether families, which is like a lot cheaper, and measuring whether families are able to continue to visit just as often with this new cheaper way, just to make things more sustainable. Next. And we are doing this at a state level. Me with Dr. Parker are the co-PIs of these. We trained 5 hospitals in year 1 and 7 hospitals in year 2. So hopefully if you invite us a year from now, we'll have a lot more to share from what these units learned. Next. But so far, things are looking good in the state. Next. And this is the one resource I want to leave you with. If you click on that link, we have built like how-to modules for each of the steps I was talking about, with just the things that we learned from our teams. So if you go down, that one. So we have 6 modules that go from the very basic why this is important, like they are very brief, they are 10-15 minutes each. They have lots of examples. And then it's like how to select a tool, how to build a resource guide, how to implement it in your unit, with various scenarios of like how to fit it to your context. So hopefully those are helpful. Please share them with anyone who's interested in embarking on this work, and please email us with any feedback. We're happy to improve it over time. Next. I think that's it. Like the last one is just conclusions. Yep. Next. Yep. So basically, this type of thing just augments our ability to provide social care. And this last slide is just for you to read, because we heard a lot of these when we first started, and it has been really inspiring to see how staff was so hesitant in the beginning and how they are so bought in now, a year into this type of work. So how it evolved was really awesome. Next. That's it.
Thank you so much, Gaby. I wish that we could give you an hour and a half, Priya and Sangeeta an hour and a half. Thank you all so much for participating in today's webinar. We really appreciate all of the great questions that were sent in on the chat. Please be sure to go on our website, fcctaskforce.org, and subscribe to our mailing list so you can have access to future webinars and the answers to all of these awesome questions that we'll be sure to get out next week. Please don't forget to join us for our next webinar on March 14th. We're going to be talking about family-centered care curriculum with the Beth Israel Deaconess Medical Center's Emily Witzel, Molly Faust-Wiley, and Kathleen Toland. And then we're also going to be talking about skin-to-skin care with Gaby. So please, again, don't forget to just subscribe, and thank you all again so much for joining us today.
Thank you guys for inviting us.
Thank you, Gaby. It was
So
wonderful.
touching to see what you're doing in your whole area. Thank you.
Thank you, Gaby. And thank you, Priya and Sangeeta. It's a wonderful presentation.
Sorry to have to rush you at the end.
Thank you, everyone.
You did amazing.
Bye.
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 Bye. Thank you so much.
Thank you.
Thank you so much.